Thank you very much for the introduction. Dear colleagues, I'm very happy to be here this morning and would like to thank Peter Kotenko and the organizing team for inviting me. It's a long way from home, but it's great to be here in Los Angeles and talk to you about, I think, a subject which has been close to my heart for, let's say, many years, and where I actually also started my research career in. And it's a problem which we commonly see, I think, in our dialysis population, and which is also of great clinical interest. I do not have that many disclosures which are of relevance for this talk. And without further ado, I will go to the outline of the talk, and that's what I will discuss with you is the definition of intradialytic hypotension, which has changed a little bit over the past years, and also gave us more insight into, let's say, what actually which are the actual blood pressures which are dangerous. There's some new data on epidemiology of intradialytic hypotension, and importantly also I'll discuss why intradialytic hypotension is related to outcome. And finally, I will discuss on the mechanisms and importantly on the prevention of intradialytic hypotension to give you some recent insights on this. Yeah, what are the definition of intradialytic hypotension? And the older definitions from KDOQI or the European Best Practice Guidelines, actually they combined both decline in intradialytic blood pressure in combination with symptoms or interventions. And this have been long used in the literature and also in, let's say, novel guidelines. But what we actually also have been learning is that it's not only the drop in blood pressure per se, albeit 20 or 30 millimeters mercury, but actually that the lowest blood pressure, the nadir blood pressure, and especially a nadir blood pressure below 19 millimeters mercury, might be of great relevance in relation to outcome. So this has been a little bit of a shift in paradigm of what is really important in relation to outcome, and I'll discuss this further with you. How often does this occur? And you see that a fall in blood pressure, as you can see here in the lower part of the slide, actually occurs quite frequently. In most of the patients, the blood pressure falls of 20, 30 millimeters mercury, and in itself this is likely not so bad, because when a patient is hypertensive, actually you want to have a small decrease in blood pressure, because this might even be beneficial and point to correction of fluid overload. But if you look at the definitions by the HEMO or KDOQI study, you see actually that the incidence is somewhat lower, between 10 and 20%. Whereas the nadir 19 millimeters mercury definition has an incidence of approximately 10%. And this was studied in an American population. And if we're now going actually to look at, these are European data, and these are data also from the Netherlands, from colleagues of mine in Groningen, and they also looked at the different definitions, and you see that actually there's not so many difference over the world. The US incidence of hypertension actually quite coincides with data from other parts of the world. And this is actually a meta-analysis of this group, where they combined different studies over the world and came to a combined incidence of approximately 10%, looking at KDOQI, ABPG definitions, and the nadir systolic blood pressure definitions. So approximately 10%, which is a little bit lower than the 10 or 20%, which is commonly actually cited in the literature. And importantly, which is the association with the mortality risk. And what turns out here is actually a little bit different than what we actually thought, that it's not so much the fall in blood pressure or even the presence of symptoms by the KDOQI definition, which you see at the lower part of the slide, but it's really the absolute decline in blood pressure below 90 millimeters mercury, which carries the highest risk with hypotension. And actually this is also in a way logical, because then you come into the area where you can have perfusion problems, and most likely it's not so much the blood pressure per se, but the decline in perfusion, which is of importance for the outcome of the patients. And I'll also give you some examples of that. I do not have a slide here on the relation between hypotension and quality of life, and there are not so many data on that. But there were some new studies in 2019, also from the Groningen study group exploring this. And actually what turned out is that the common definition of hypotension did not carry a relation with the SF-36 score, but they carried a relation with the patient-reported intradialytic symptom score. So many of the aspects actually which are of relevance for the patient are not, let's say, are not always adequately captured by SF-36 scores, and we have to go, I think, into more detail if we really want to know what, let's say, some of the complications actually mean for our patients. So it carries a relation with quality of life, but actually you have to go into some more detail to find this out. But importantly, a relation also with mortality as shown here, but especially in relation to the lower absolute systolic blood pressure. And it's not only, it is also of importance not only that you have intradialytic hypotension per se, but also how often you have an intradialytic hypotension. And this is a recent study actually from approximately 5 years ago, where you see that the progressive increase in frequency of intradialytic hypotension is actually associated with an increase in all-cause mortality and cardiovascular mortality. So not only if you have once a low blood pressure below 90, it does not necessarily carry a risk with outcome, but especially if you have a high frequency of episodes of intradialytic hypotension, this is related to outcome. And yeah, what could be the mechanisms? Is it the intradialytic hypotension per se leading to organ ischemia, which could be of importance in relation to the effect, the relation between hypotension and outcome, or could also comorbidity play a role, because patients with severe comorbidity can also be at higher risk for intradialytic hypotension. And there are some arguments actually that it's actually also the hypotension per se which is of importance, and I'll show you some data on that. And importantly, actually, a recent study by the group from RRI looked at a novel risk marker, and that's the central venous oxygen saturation measured by the crit line in patients with a central venous catheter. And actually what turned out is what you can see on the slide in the red line, is that the patients with the lowest tertiles of central venous oxygen saturation actually had a far higher mortality. And central venous oxygen saturation is actually a combination of actually the difference between the oxygen delivery to the body dependent on cardiac output and arterial oxygen content and the oxygen consumption. And actually we can assume that a lower central venous oxygen saturation is also due to, for instance, a lowering of cardiac output. And here you have a kind of a direct proof that changes in organ perfusion, differences in cardiac output can actually matter for survival. And this has also been, let's say, shown in data from, for instance, the group from Chris McIntyre, who also looked at the change in blood pressure during dialysis and looking at cardiac stunning. And cardiac stunning is a reduction in regional contractility, which is reversible. And what the group of McIntyre showed in many times actually is that a decline in blood pressure is related to an increase in cardiac stunning. And this increase in cardiac stunning is actually, when you look over 1 year, is actually associated both with an increased mortality and also with cardiac dysfunction, which becomes permanent. So it's not an innocent phenomenon. This cardiac stunning, which may occur due to changes in blood pressure during dialysis, can in the end become permanent and be related to increased mortality. And also new data actually looking at the interaction between intradialytic hypotension and cerebral ischemia. And here the autoregulation comes also into play. And what is likely is that when your blood pressure declines below a certain threshold, the cerebral autoregulation can become insufficient, and really you get a cerebral ischemia. And this is a study actually looking at the relation between mean arterial pressure during dialysis and the saturation in the cerebral arteries. And also this can have long-term effects. actually, because there's also a relation between intradialytic hypotension with the new onset of dementia, and the prevalence of vascular dementia in dialysis patients is actually quite high. And what it shows here is that there's a relation between patients with, again, frequent intradialytic hypotension and the risk of new onset dementia. So cardiac problems, cerebral problems are all related to frequent blood pressure decreases during dialysis. And yeah, so it's actually important that now knowing actually that it can be related both to mortality, to organ dysfunction, what is the pathophysiology of intradialytic hypotension, because here is also the key to prevention. And some of the data which I'm going to discuss with you are relatively old, because there's some very important insights which have been gathered already in, let's say, the early 2000s, 1990s, but also there are quite some new data on the pathophysiology of intradialytic hypotension. And I'll mainly discuss with you the decline in blood volume and impaired vascular resistance and venous tone, and I will not go so much into detail about the impaired cardiac response. First about the decline in blood volume, because there's quite some new data from that, and also some new data from Renal Research Institute, which I'll show you in some minutes. But why does blood volume decline during dialysis? It's actually quite simple. You have an intradialytic weight gain, which you have to remove by ultrafiltration. And actually, the higher your ultrafiltration rate is, the higher your risk of a decline in blood volume. But there's also a very important phenomenon there. You have refilling. And if a patient is fluid overloaded, there's a lot of extracellular flow fluid available for refill from the interstitial compartment to the plasma volume compartment. So part of the ultrafiltration and decline in blood volume, which we see during ultrafiltration, can be compensated for. And this is actually what you can see then in the blood volume curve, for instance, by a grid line method, but there are also in, let's say, other ways, looking, for instance, at ultrasound during dialysis to look at the change in blood volume during dialysis, basically based on hemoconcentration. And what did we actually know about intradialytic weight gain and the risk of intradialytic hypotension? And what shows here in this study from 2014 from Stephenson is actually that the risk of intradialytic hypotension increases with higher intradialytic weight gains, which is also, of course, logical. And how does this work? So we have an increase in weight gain. This necessitates a rapid ultrafiltration rate, and especially if you have short treatment times is very important. It's likely not just the ultrafiltration volume per se, but mainly the ultrafiltration rate, which exceeds the refill, which increases the risk of hypotension. And hypotension, as already seen, actually increases the risk of hypoperfusion, myocardial stunning, and in the end also end organ damage like cardiac damage and cerebral damage as shown previously, and this contributes then to increased morbidity and mortality. And most likely the relation between high intradialytic weight gain and mortality is due to this pathophysiological explanation. But can we actually know which patients have a kind of a critical relative blood volume below which hypotension occurs? And these are data from Claudia Barth. And actually what it shows is that the relative blood volume at which hypotension occurs can differ greatly between patients. You have patients actually who can tolerate virtually zero decline in relative blood volume, and most likely these are the patients who are cardiac compromised, whereas likely young and healthy patients can tolerate fluid removals and decline in blood volume up to 20% without actually apparent ill effects. These are patients, actually it's important to realize that these are the thresholds at which intradialytic hypotension occurs, but we do not know where these patients, even in the lower range, experience end organ ischemia. That was not studied in this paper. But it's not just actually the decline in blood volume, a high decline in blood volume, which may be deleterious. And if we look at the relation between outcome, and it is actually quite interesting, these are data also from RRI, and actually it showed that the highest risk of mortality occurs in patients, if you study these blood volume curves, who actually have a very low decline in relative blood volume. And you can see here that the hazard ratio is actually highest, is for instance, if you decline in relative blood volume is only 5 till 4%. Whereas the patients actually who experience a higher decline in relative blood volume actually have a better survival. So here seems to be a kind of a paradox in play. And what we know is actually from relative blood volume that it's a composite parameter of fluid, maybe of overhydration and ultrafiltration rate. And we know that the major decline in relative blood volume is related to intradialytic hypertension. We have a large inter-individual variation, most possibly due to comorbidity. And very importantly, it's mainly the flat curves which are related to mortality. So actually, a putative scheme could be that the flat curves are a marker of fluid overload, or maybe also of an intolerance to fluid removal, and that actually explains the relation between the flat curve and increased mortality per se. Now to the next mechanism. I've been talking about decline in blood volume, which you see at the right part of the slide. And what I would like to discuss now is the systemic vascular resistance and venous stone, actually, which might be a little bit different, the reaction of the venous system and the arterial system, than what you normally observe during a decline in blood volume. And in a healthy subject, if you have a decline in blood volume, your peripheral resistance needs to increase and your venous stone needs to increase to mobilize blood volume from the peripheral compartments and from the splanchnic venous system to the heart in order to maintain blood pressure. And that's actually why, let's say, healthy subjects, trauma patients, can actually tolerate declines in blood volume up till 20–25% without a decline in blood pressure. But in dialysis patients, this seems to be altered. And instead of an increase in venous stone or an increase in systemic vascular resistance, this can sometimes be, this increase can be insufficient for the decline in blood volume. And this can be due to, for instance, autonomic neuropathy, but there's also some evidence that also thermal stress during dialysis actually plays a role in skin vasodilation by an increase in blood pressure, which actually you get a kind of a conflict between the reaction of the peripheral vascular system in relation to the decline in blood volume, necessitating vasoconstriction, and an increase in core temperature, which can occur during dialysis. Let's call it a kind of a mini heat shock, which actually leads to peripheral vasodilation. And here I think history comes into play, because I think it's always nice to look back into history, and these observations actually looking into the potential effect of temperature were already made in 1976. And this was done by Jonas Bergström from Karolinska in Sweden. And actually what he showed is that you have, when you compare isolated ultrafiltration, when you do not have fluid removal with standard hemodialysis, actually blood pressure remained stable during isolated ultrafiltration, but declined during hemodialysis. This was acetate dialysis, but later studies also showed that the same phenomenon was observed with bicarbonate dialysis. And actually, taking this somewhat further, Carina Maggiore from Italy performed comparative studies between isolated ultrafiltration and dialysis. And you see that at the lower part of the slide, actually looking at the difference between cooled dialysis, which has the same vascular response as isolated ultrafiltration, and just standard dialysis at that time with 37.5 degrees centigrade, during which you saw a profound decrease in blood volume. And actually these were the first evidences that temperature plays a major role in the blood pressure response, as well as the reaction of peripheral vascular system. And even with nowadays dialysis techniques, you see that on the right part of the slide by a paper from Len Ousviat, you see that especially patients who have a low pre-dialytic blood pressure during body temperature before dialysis actually can experience, even with contemporary dialysis temperatures, an increase in core temperature of up to 0.5 and even 1 degree centigrade, which is not negligible if you look at the potential hemodynamic response. So actually, dialysis, if you do not perform dialysis with, let's say, dialysis temperature of 37 degrees centigrade, can really lead, and even, let's say, temperatures of 36.5 degrees centigrade can sometimes lead to an increase in core temperature. And what we showed here, also in combination with RRI, is that when you match completely the thermal energy transfer between isolated ultrafiltration and cool dialysis, that actually you do not see any difference in the venous response or the peripheral vascular response anymore. So from a pathophysiological point of view, this actually suggests that temperature itself is actually the main factor for the, let's say, reduced vascular response, which sometimes you can observe during standard hemodialysis. But it's not only temperature, and these are some more novel data, actually looking, for instance, at potassium. And what this slide showed is that it's when you lower the dialysate potassium concentration, actually you can also, this can have an effect on blood pressure. It's not that large, between 5 to 10 millimeters mercury, but especially in susceptible patients, this can be maybe be critical. So let's say lower the dialysate potassium levels, and actually also higher dialysate bicarbonate levels can also have some effect on blood pressure response during dialysis. And in the case of low potassium levels, this also seems to be due to an effect on the systemic vascular resistance. So mainly temperature has an effect on the peripheral vascular response, but there are also dialysate concentrations, potassium and bicarbonate, which can be of relevance here, and which you could modify in a patient with frequent dialytic hypotensive episodes. So I will not discuss the scheme with you in detail, but I'll only discuss some of the parameters mentioned here. And I'll focus on an increase in dialysis time, discuss some aspects of blood volume feedback, dry weight assessment, and I'll discuss cool dialysis and mid-routine. I will not go into detail on hemodiafiltration because I will discuss this in the pro-con debate with Bernard Cano on Friday. But firstly, it's very logical to increase dialysis treatment time. And these are data from the frequent hemodialysis network, looking at the FHN daily trial on the left part of the slide and the nocturnal trial on the right part of the slide. And actually what it shows, this is a combination of mild and severe. Level 3 is severe intradialytic hypotension, where you really have to do a lot of maneuvers to stabilize blood pressure. And what it showed is that especially in the normal group, actually the intradialytic hypotension nearly disappears. In the frequent daily, it also declined, but the major effect was actually observed in the nocturnal trial, which is logical because you actually remove your fluid over a long period of time, and you can keep your ultrafiltration rates low. Now about blood volume feedback, and until now, actually, despite actually all the interesting evidence which we have obtained with blood volume curves, it has not been shown yet at this moment that it results in a reduction in intradialytic hypotension. And even some older studies actually showed an increase in complications and mortality with the use of blood volume controlled feedback. But these were different algorithms that might have been used with the wisdom of today. And this is the most latest trial actually from Korea, looking at control in gray biofeedback, blood volume controlled biofeedback in black. And actually they tried to prevent a critical decline in relative blood volume, but in the end, actually the incidence of intradialytic hypotension was not different between both maneuvers. But let's say when you looked at long-term outcomes, there was also no ill effect of blood volume controlled feedback in this study. Looking at temperature control, actually, these are data which are already a little bit older, again from Quirina Maggiore, actually when looking at patients who, in a randomized trial, where they controlled body temperature in this way, also by biofeedback module, keeping body temperature stable. You also see a nearly 50% decrease in the incidence of intradialytic hypotension. And actually also from lowering dialysis temperature, there's most evidence. This is a systematic review, and actually you see that there's a, if you look at the lower part of the slide, a significant reduction of intradialytic hypotension with the use of thermal-controlled or cool dialysis temperature. And in our unit, we, in susceptible patients, we use, let's say, as a minimum 35.5 degrees centigrade. We do not really go lower, because then patients can also experience side effects like shivering, which can also be quite uncomfortable. But also importantly, this is an RCT from the group of Chris McIntyre again, and which also looked actually at cardiac protection by cool dialysis. And actually what he showed is actually that over a period of a year, nearly all cardiac parameters were actually better, were preserved with cool dialysis temperature as compared to standard dialysis temperature. And actually also importantly, coming back again to effects of hypotension on cardiac, but also cerebral ischemia, also brain white matter was better preserved with dialysate cooling as compared to standard dialysis temperature. No effect on mortality though yet. That's actually, these studies have been too limited, maybe too underpowered, actually to look at the effects of dialysate temperature reduction and heart outcomes. It's just not there yet. It's only the data which we have are on intradialytic hypotension per se. But beyond that, this is a study looking actually at facility practices. Interestingly, actually looking here at the prescription of cool dialysis, it did not have a significant effect. But what had a significant effect on reduction in intradialytic hypotension is actually the frequent assessment of dry weight, just probably in this case clinical dry weight, but just frequently looking at your patient can be of help in reduction of intradialytic hypotension. Whereas what was associated with an increased risk was sodium modeling or profiling. So this is actually probably something which I would not advocate. Then as last slide on the prevention, the impact of midrodine, an alpha sympathomimetic agent. And actually what it showed in this recent, this is an observational study with matched controls. So we have to be a little bit careful in the interpretation. But actually what it shows is that there was not a reduction in intradialytic hypotension with midrodine. If anything, systolic blood pressure was lower. But we have to be a little bit careful here of residual confounding. And also an increase in hospitalization and death was higher in the midrodine group, which does not mean that it's causally related to the use of midrodine. Again, there can be residual confounding, but we do not really have evidence that midrodine is effective from all the studies, certainly not when you compare it to cool dialysis. So what works in intradialytic prevention? Frequent assessment of dry weight, aiming to reduce intradialytic weight gain by sodium restriction can be of help, prolonging dialysis time and frequency, and reducing dialysate temperature. What does not work at this moment, at least what we know, but there might be blood volume controlled feedback, can with the new insights, maybe we have a kind of a golden zone where we should aim for, can still be of relevance, but I think it needs more clinical studies to show this. Sodium profiling I would not advocate because it also can be associated with potential harm, and midrodine also has not been shown really to be effective in addition to cool dialysis, and we have some observational data where, let's say, harm cannot be completely excluded. So, coming to the conclusions of my talk, is that we know from recent literature that intradialytic hypotension occurs in approximately 10 to 15% of dialysis sessions. It's also dependent on the definition. And it's not so much the decline in blood pressure during dialysis per se, but especially the nadir blood pressure, which is consistently related to mortality, especially when it occurs frequently. And the association with mortality can be causal. We have actually quite some evidence for that it can lead to decline in organ perfusion, which can have permanent effects in the long term. But it can also be related to underlying disease because patients with cardiac dysfunction, autonomic dysfunction, may by definition be more prone to intradialytic hypotension. The pathogenesis is multifactorial and is based on a combination of decline in blood volume, sometimes an impaired vascular resistance if your dialysis temperature is too high, or maybe you get a profound hypokalemia, and cardiac dysfunction. And yeah, we perform dialysis 3 times weekly usually, and we have to remove all the fluid in 12 hours, which normally accumulates during 168 hours. So probably it's not completely preventable just due to the nature of the treatment itself. But there are, let's say, I think, powerful methods to reduce its incidence, like reducing interdialytic weight gain, frequent assessment of dry weight, and adjustment of dialysate temperature. And with this, I would like to close and would be happy to take any questions with the panel. Thank you.